on the 5th of that. On behalf of, so my name is Baya Oladele, and on behalf of the organizing committee, led by my wife, Mrs. Yinka Oladele, and Mr. Kenoe of the Walnut Foundation, I'd like to welcome you to our very first across the nation webinar on cancer awareness, focusing specifically on prostate cancer. Today's event is organized by the African Cancer Support Group of the Oladele Foundation here in Calgary, Alberta, in collaboration with the Walnut Foundation of Toronto, Ontario. So you follow me as I walk you through. I want to tell you briefly about, before I hand you over to the moderator of the day, I'd like to talk about African Cancer Support Group.
1 second.
Okay, so African Cancer Support Group was founded a couple of years ago to help survivors, patients cope with emotional traumas caused by cancer disease. And our aim actually is to support survivors, to support patients and caregivers, and to share memories, stories, symptoms, informations, and coping strategies. So African Cancer Support Group is a safe place to share information, coping skills, and most importantly, a place to give and to get emotional support. So why should you join African Cancer Support Group? Being in a support group encourages healing and can help everyone develop new skills to relate to one another. Next slide. So about African Support Group, who can attend? African Cancer Support Group is designed for specific audiences, including most especially Africans, Black individuals living with cancer, cancer survivors, cancer patients, caregivers, family members, and friends, and anyone interested in knowing more about cancer. The group meets bi-monthly. Actually, we meet every month. However, bi-monthly, we invite professionals to come and share information about cancer. And so every second Sunday of every other month via Zoom, for now, we meet for 2 hours between 4 and 6 p.m. And we also meet bi-monthly, and this is for the members of the group to share and encourage one another. And the next meeting for our for the members group meeting will be on November 14, 2021, which is just about a month and so from now. Next slide.
That's it.
Oh, so now I'm going to now pass you on to Mr. Kenoe of Walnut Foundation Ontario. Is going to introduce himself to you. He's going to moderate the event today, and he's going to give us some information about Walnut Foundation. Mr. Kenoe.
Thank you, Bayo. It's a real pleasure being here tonight, and just to point out that the African Cancer Support Group is based in Calgary, Alberta. The Walnut Foundation is based in Ontario. So it's a real pleasure to actually team up with the African Support Group to put on this event tonight across Canada and into the Caribbean as well. Because I believe we have people from the Caribbean, we have someone from India joining us tonight, and we really do appreciate you being here tonight. It's a couple of things that housekeeping issues. So all lines will be muted during the presentation. We're going to record this presentation and make it available on our websites, both websites. Also, we're going to send an email out to the registrants after the presentation with a link to actually view it again. Also, there's a survey that's going to be in the link. Please complete the survey. This would help us to plan better events as well. So in terms of questions for the presenters and panelists, please enter your questions into the chat, and then we'll address each question. Hopefully we can get to all of the questions tonight, and I'm sure there are going to be a lot of questions for us this evening. So this is a disclaimer that we need to specify. So both the African Cancer Support Group and the Walnut Foundation, we do not give medical advice. So the experiences that expressed by the survivor panelists are the lived experience of the Walnut Foundation and the African Cancer Support Group. We do not recommend medical solutions. Medical solutions are for people like Dr. Vesprini. So for medical treatment, we advise people to consult your doctor or your healthcare team about specific situations. Okay, so about the Walnut Foundation. So we're a men's health interest and prostate cancer support group. We're based out of Brampton, Ontario, but our support goes across the entire GTA and into the Caribbean as well. So our purpose is to work with the Black community in the Greater Toronto area in identifying the needs of Black men and their caregivers in the area of health and related issues, and to provide them a forum for discussion in a comfortable, safe, and supportive environment. So that's who we are. Now, how we provide our services. So we normally have an annual conference on men's health. It's held in the fall every year. It's now virtual. We have a free symposium as well that we do on different issues.
I think we lost them.
Okay, I can continue on that. Before Mr. Ken comes back, he's trying to tell us that how Walnut Foundation serve, how the way they actually deliver their services. So they have the annual conference on men's health, which is usually now virtual. They have annual free symposium in February, now virtual. They have monthly meetings with formal presentations and discussions, also virtual. They have corporate, community, and church presentation. You have guide-to-guide support, which we have 2 trained peer navigators, and they collaborate with other groups, just like they're collaborating with African Cancer Support Group now. And of course, their funding comes through annual workout. And the last thing for the why we do this, maybe I can actually share my screen now that sorry about that. Let me just share my screen too, and then here we are. I hope you can see my screen.
A bit fuzzy. Okay.
All right. So why are we doing this? This is for the Walnut Foundation. So in Canada, actually, the point here is this: why are we focusing on the Africans? Both the Walnut Foundation and the African Cancer Support Group. Why do we focus? Yes. Oh, are you back? Okay, so it says men of Afro-Caribbean and West African descent are 50% more likely to be diagnosed and 2 times more likely to die from prostate cancer. This is what has been found out, and I guess our doctor will talk more about this one today. So if caught early, the survival rate is almost 100%. And that's one of the reasons why we want every man to be tested. Go out and get tested. The next point is that USCDC, this is from down south, found that the rates of death from prostate cancers are 2 to 9 times higher in the Caribbean than in the United States. The study also reported that prostate cancers accounted for 80% to 47% of cancer deaths. And this is for Caribbean. And they said, if you look at the chart, if I do this, you will see that the chart, the male and of course the female, all races, 21.4, white, 19.8, black, 46.3%, and Asian, American, Hispanic, and you could see that. So that is why we are doing this, just to help ourselves to reduce the death rate and so on and so forth. And that will be the end of that. And then we will pass it on to, is Mr. Ken back?
I haven't seen him as yet. I hope he can come in soon.
Okay, so I guess, okay, if it's not.
Perhaps I can just introduce Dr. Vesprini, and then we take it from there.
Okay, so we need to introduce Dr. Vesprini. Thank you. And I'm going to remove my screen. Stop sharing. Okay.
Okay. So Dr. Vesprini is no stranger to the Walnut Foundation. He's a radiation oncologist who treats both prostate and breast cancer at the Sunnybrook Odette Cancer Center in Toronto. He's an affiliate scientist in the biological sciences at Sunnybrook Research Institute and an assistant professor in the Department of Radiation Oncology at the University of Toronto. Dr. Vesprini's research includes a focus on genetic predisposition to aggressive prostate cancer. He's one of the principal investigators of the Sunnybrook Active Surveillance Program, as well as the director of the Male Oncology Research and Educational Program, which focuses on men at increased risk of developing prostate cancer, including men and with a strong family history of the disease, men with a BRCA mutation, and men of Caribbean West African heritage. Dr. Vesprini goes home. When Dr. Vesprini goes home, he remembers that he is married to an incredibly understanding and patient wife with whom he shares 2 perfect children. And I want you all to join me in welcoming Dr. Vesprini and to thank his family for sharing his time with us.
Yeah, they're probably happy I'm not home. Let's not kid ourselves here. Yeah, so it's great to be here. That's that introduction is very nice. I'm not sure I deserve a lot of that. It sounds like I do a lot of things, but I do them all half-assed, as they say, I guess. But it's a great honor to. And you guys can see one screen there.
Yes,
we do.
So I really do enjoy these types of events, and I'll go through a little bit why I think near the end of my talk about how this kind of advocacy, not on my behalf, but on your behalf and the people that are joining in is really the most important part, I think, of trying to improve how people do, particularly men and women from the Caribbean and Western Africa, mainly because awareness, attitude, perception is probably the most important things that we can deal with. Now, a lot of my research is genetics and background in science and kind of the high-tech stuff of radiation. But in fact, I think, this kind of stuff, this kind of information awareness and discussion is quite frankly, I think, more important than a lot of the stuff that we do that gets, I guess, it is a bit more sexy, but it doesn't necessarily help as many people. And I apologize for anyone that's kind of seen these talks before, but I always like to start off with just some very basics about cancer, because I think that sometimes when people go into talks, particularly those that we give that are about our research and the things that are going on in hospitals and in research institutes, is we kind of jump into it. And I think that the basic knowledge of what we're dealing with sometimes is lost in that. So I'd like to go a little bit through the basics of cancer and maybe in particular prostate cancer. So, you know, as we all know, the body's made up of multiple organs. These nice illustrations show. Each organ is made up of multiple sets of distinct cells. They all have a common ancestor, and then they develop into different aspects of cells. It's all very complicated machines. There's about 100 trillion cells within the human body. You know, goes up and down a little bit depending on how big your belly is. And then most of these tissues and organs are made up in cells that we call a steady state. Is that, you know, once your lungs are a certain size, that is what size they're going to be. And then, you know, cells will continually die and be regenerated, but they continually go into that same form and that same more or less amount of cells and tissue that gets made up. So what cancer is in this depiction here, if you're looking at, these are cells that are growing in a petri dish in a lab. If you put down normal cells into that petri dish, they will grow and then become what we call confluent. So they're completely covering the bottom of that vessel, and they stop growing. And that's something called contact inhibition. When cells touch each other molecularly, they give signals to each other to stop growing. So then they'll just stay stagnant, much like your skin is like that. It doesn't kind of grow over unless you develop some types of skin issues. When you transform a cell, and that's what we do in the lab, where we put something in a cell to make it look like cancer or grow like cancer, those cells will then grow, and then even though they're touching each other, they stop that, they no longer have that contact inhibition. They keep growing, and you'll see cells will pile on top of each other. So this is kind of one of the ways that we view cancer is that cells lose the ability to stop growing even when they're in an environment or they're in a situation where they should. They'll just keep growing and growing and growing, and that's what a tumor is. Doesn't define exactly what cancer is, but that's one of the premises of cancer. So cancer in such is a disease where these abnormal cells continue to divide without control. They just keep going. And then eventually, not to be anthropomorphic and give them as if they have a free will, but they then learn how to invade other tissues and organs. And that's what we call metastasize. So some tumors just grow in one spot, and they grow there, and they can cause damage because they push into things, but they never become invasive. They never invade into tissues and spread. But a lot of tumors, a lot of cancers will eventually acquire those genetic or what we call epigenetic changes that eventually then gain them the ability to grow other places in the body, get through the bloodstream, and metastasize into other organs. And that's what, you know, that's the main issue of the majority of cancers, is that it's not the actual local disease. With prostate cancer, you know, prostate cancer cells are prostate cells. They, like cancers, don't know they're cancer. They don't know anything. They're just cells. And they, under the microscope in most cases, will look like a prostate cell. Prostate cells make PSA, prostate-specific antigen. That's the protein that we look for in the blood of men as a screening tool. PSA is just a enzyme that is helpful for sexual reproduction. So these prostate cells, no matter where they go in the body, are still prostate when it's prostate cancer. And what happens is that as a cancer evolves, it starts to accumulate mistakes inside of its genetic material that, again, stop them forget to stop growing, so they no longer touch each other and stop growing, and then eventually gain the ability to grow somewhere else. And I tell this to all my patients because people worry about biopsies. Is it going to spread things? You know, is it going to get into my bloodstream? The reality is that, you know, almost every cancer is in your bloodstream if you have it. We can take blood out of people that have cancer, and we can find what they're called circulating tumor cells. So they are cancer cells that have access to the blood, and it's because it doesn't like find a way into the bloodstream and then go away. It's in there. It always has access to blood, because tumors make their own blood vessels. They have their own blood supply. So these cells are always coming off and floating in. The issue is that the majority of cancers don't have yet the ability to grow inside other parts of the body. You could take a chunk of prostate cancer from a man and insert it in a nice little way in someone's hand under their own skin, in their own body, and it won't grow because it doesn't have the ability. It needs to be in the prostate, in that milieu of whatever is going on there to have it grow. So, but cancers, as they become more aggressive, will acquire the ability to get more access to lymph nodes, to blood vessels, and then actually grow there outside of the normal environment. So that's kind of, that's the evolution of cancer from a tumor that may just be local into something that eventually learns how to grow somewhere else. And I guess the question always is, how does it start? And this is a simplistic way of looking at it, but it's common in the majority, is that, you know, our cells make a mistake. Something happens that triggers that cell to no longer stop growing. It just keeps dividing and dividing and dividing. And these mistakes are most commonly in our genetic material. So in our DNA, so that's the blueprints that we have in every single one of our cells, or RNA, which is the transcription of that blueprint to then make into proteins and all the things that are needed. And there's all these other changes that we've become more aware of, but they're all mostly genetic changes. So something that gets passed on as that cell divides into two, it has two copies of the same genetic mistake. And we know that our body makes mistakes all the time. Like every single cell makes mistakes every single day. That's just the nature of things, you know. And we know that from as we get older, the rates of cancers go up, and that's just because the longer you live, the higher the chance you're going to get cells that have these mistakes that end up giving it an advantage to grow or metastasize. And that's kind of what the epidemiology, so the kind of the studying of patterns in population, is that as we get older, you know, the rates of cancer go up. If you live long enough, you're eventually going to get some form of cancer. So I guess why are these mistakes? So, you know, recall we have like well over a trillion cells in our body. Each of our cells has all of our DNA. So our blueprints. In that, there's 3 billion letters. Only 2% of that, though, is actually useful for genes. The rest is what we consider junk. It probably has purpose. We just don't know what it is yet, so we call it junk. But so of those genes that are used to make our hair, our skin, all the things in our body, there's still a lot of information there. So over 200,000 pages if you put it into a book of DNA. In every single cell, there's between 1,000 and 1 million mistakes made in that genetic code. That's just the way it goes. It's the normal metabolism of the body and the way things are going. And now, most of those mistakes will happen in the junk DNA. They won't happen in the genes, but about 2% will happen in the genes. That's between 20 and 20,000 mistakes in our genes in every single cell of the trillions of cells we have in our body every single day. That's a lot of mistakes, and eventually something might happen in a gene where it matters. Now, thankfully, we have a very intricate molecular way to repair all this DNA. Otherwise, you wouldn't live. You would have too many mutations that would cause problems that are incompatible with life. So the vast majority of these mistakes are repaired. For example, bacteria, virus, COVID, the reason why they mutate so quickly into something is they don't repair their DNA well, because they don't need to, because they don't need to have children. You know, we've developed that through evolution. I apologize for any creationists that are here, but we've evolved to a point where to live long enough that we can have kids and make sure that they're good enough to have their kids. But bacteria, viruses don't, because they don't have an organized system, and it's also just a matter of its survival of the fittest for them. So viruses keep mutating and mutating and mutating. You don't want to repair your DNA if you're trying to get an advantage against an organism or advantage to survive. So multiple mutations happen. Eventually one has what we call a gain of function, and that becomes the more dominant virus or more dominant bacteria. Cancers are kind of the same. And we accumulate these mistakes naturally, but also by carcinogens in the environment, the chemicals we're exposed to. There's radiation in the air from nuclear accidents, from nuclear bombs back in the war, from all the nuclear testing. There's smoking, which obviously people give to themselves. There's radiation that we get from imaging, from x-rays, from CAT scans. There's radiation in the dirt. So every time you go in your basement, you're exposed to radiation. It's called radon. It's a gas that comes out of the rocks, which are here from the earth being developed. You can get mistakes from infections. So there's some very well-known ones. For example, HPV, it's a human papillomavirus that causes warts. So it was traditionally thought to be it was a sexually transmitted disease. It's far more common now. That increases the risk of cervical cancer in women. It's now one of the leading causes of head and neck cancers because of all the oral sex over the years, and that virus now migrating up, not just being in the genitals. There's nothing known for prostate cancer yet, but these viruses can cause these mistakes. That's why vaccines work. So, the vaccine for human papillomavirus is going to monumentally change the rates of cervical cancer in the future. As our children get vaccinated from this, they are much less likely to develop these cancers. And lifestyle, right? So we all have lifestyles that introduce mistakes in our DNA. Smoking is one of the big ones, the stuff we eat, barbecue, all these things do. The issue is that human beings are really good at pointing out the stuff that they can't control as being the problem. Oh, it's the nuclear accidents, and it's this, and it's whatever, and it's my doctor doing x-rays. But a lot of the stuff is stuff we control. The problem is that we're also, a group of people that don't want to change what we do to help things. And, like as Cookie Monster here doesn't want to eat vegetables. I think there are some things that we can control to minimize that. And that's why healthy diets and things like that are so important to minimize, I think, overall cancer risks. So nutrition is a big thing. It's in regards to prostate cancer, there's really no known impact. There's studies that show maybe a little bit of this, maybe people have too much barbecue, maybe people have a high fat diet. It's very hard in population to determine whether that's the actual cause or it's just associated with it. And sometimes association doesn't mean it caused it. It just means that whatever that activity is associated with the risk. So there's vitamins, conflicting data, lycopene, selenium, vitamin E, vitamin D. Some studies showed increased risk, some studies repeated showed decreased risk. It's really unknown whether it makes a difference. Diets, those populations that have diets in high animal fat tend to have more prostate cancers. Again, that doesn't mean it's the cause, it could just be associated. And the one thing I like to compare that to in my breast cancer practice is that, having a university education is associated with having breast cancer. Clearly, that's not the cause of it, but it's just women that go to university have other risk factors that increase their risk of breast cancer. So sometimes you might read something that they say so-and-so is associated with prostate cancer or lung cancer or cervical cancer. It doesn't mean it's the cause. It just means those two things are associated. Calcium, dairy, these are all things that you're going to read about. There's no great evidence it makes a big difference. There was a big study years ago. Looked like milk increased the risk of prostate and breast cancer. And then it was only the high fat milk. And then it came, it was only the low fat milk. And then it was another study. So there was no association with milk. So, you got to be very careful when you read one or two things about something and then just assume that that's the truth. And lots of supplementation. I'm sure there's people on this call you've heard or whatever, you take this thing and there's stuff on the radio and prostate health and blah, blah, blah. I think we really don't know. All we do know is that, that's a major billion-dollar industry selling people things with claims that they work, but there's really no great evidence that it does, despite people's good intentions. And a lot of times it really is marketing, right? So this, you can, it's not, this is being very cynical, of course, but you could easily just have all of a sudden, it sounds like, cayenne pepper is the thing, and then the companies are going to make everything with damn cayenne pepper because it's going to sell like hotcakes. So sometimes it's about where things are going, not necessarily where the evidence is. So you have to be very skeptical when it comes to all these supplements that say that they help when you have cancer or they decrease the risk of getting it. Ultimately, my research-wise, that you can blame your parents because we do inherit some of these mutations through our genes. And some people are born what's called a first hit. So they already have a mutation in a gene that gives that cell an advantage or disadvantage, if you want to look at that way, of becoming a cancer. So the most common one we know about is BRCA1 and BRCA2, so the breast cancer genes, right? That's the one of the genes that Angelina Jolie had. So women with these genes eventually will get breast or ovarian cancer. It's incredibly rare for them to not get it if they live to a long age. And that's because every single one of their cells is missing a copy of a functioning copy of these genes. And keep in mind from old genetics is that you have 2 copies of each gene, almost all of them. And if you're born with one that's not working, then if you lose the other one, that may be a big problem, particularly when it's a gene like BRCA1 and BRCA2, because those genes are involved in repairing DNA. So that repair mechanism to fix all those mistakes. BRCA1 and BRCA2 are the genes that are integral. So if you lose that functioning copy of that gene, that cell that lost it is now going to make more genetic mutations than it would have. And then there's a higher chance that eventually one that happens is going to make something that is a cancer. You can't control this. There's nothing you can do about that. You can blame your parents because they gave it to you, but it's not something you can control. So you can find out about it and use that information to try to modify your risk or go into screening programs, all that stuff, but you can't, at least now, change your genes. We hope someday in the future there will be technology to change genes. There's some early stuff you can do. So for example, parents that have a BRCA1 or BRCA2 mutation, if they are so inclined and whether they have ethical boundaries with it or whatever their preference is, can only fertilize eggs or have fertilized eggs that don't carry the mutation of that gene, so they don't pass it on. That's called pre-implantation genetics. We do genetics of the fertilized eggs and you only implant the ones that don't have the genetic mutation. But that's just kind of one of the thoughts of going forward, and maybe it can be done after fertilization, after birth. So I'm going to kind of go through some of the stuff that we already looked at, and really the prostate cancer statistics for Black men is not good, and that's why it's an area of focus of research around the world, and it's something I'm interested in as well. If you look at the rate of prostate cancer, Blacks have much more incidence of getting it, so the chance of getting it compared to Caucasian men, and then in general more than Asian men. And if you look at nationality, it's very common in North America, Europe, Australia, the Caribbean. Now, it's less common in Asia, in Africa. Now, some of that's artificial. It's very common in Canada and the United States because we do PSA testing, or it's not very common in Uzbekistan because they don't do it there. So sometimes if you look, you find it. But what's important, I think, is that we know the risk factors. So independent of where you live, if you have a family history, so a first-degree relative, your dad, your brother, your son, you are 2 times more likely. If you have multiple relatives in your family with prostate cancer, you're about 4 times more likely to get the disease, or at least be diagnosed with the disease. So for example, I say that because if your brother gets prostate cancer, you are more likely to get it, or at least be diagnosed with it, because you're more likely to go get a PSA test. So there could be an artificial increased family history because people look. And again, whether there's occupational risks, these dietary fat risks and all that, that's like we talked about, I don't know. And then definitely if people have a known genetic predisposition like a BRCA1 or BRCA2 mutation, the risk of developing the disease is much higher. So this is I think you guys stole my slide. So there's 2 slides here. So this is the number of cases per 100,000 people by race. So as you can see in the schematic, Black men are almost twice as likely to be diagnosed with prostate cancer than all races combined. And if you compare it to white races, probably the biggest numbers, it's almost double. So they're 2 times more likely to get, and that's important because as we'll go through a little bit later, Black men don't get tested as much. So if you believe there's a bias, white, higher socioeconomic people should have a higher rate of getting it because they're looking, where even in the United States, where the Black men are less likely to access medical care, less likely to access screening, they are almost 2 times more likely to develop prostate cancer. And what's I think important is they are more than 2 times more likely to die of the disease. And the previous discussion is right, is that it is pretty rare to die of prostate cancer if a man is diagnosed early. It has to be treated, of course, but those men that are diagnosed early, it is pretty rare to die of prostate cancer. If you look at all men in United States, because this is American data, 46 men out of 100,000 people. That's a statistical term, so I don't think you should focus on that. It's just you're twice as more likely to die of prostate cancer if you're Black than if you're white. That becomes a very complicated reason. Obviously, genetics is maybe one of them, but there's a lot of socioeconomic reasons for that, which I want to touch on. And this is kind of shows you, like, you always look at data from the United States and Canada, but this is what we call a heat map. So the darker the color, the more likely the event is that you're looking at. In this case, this is the incidence, so the rate of getting prostate cancer in the world. As you see, there's a very high rate of getting prostate cancer in Canada, in the United States, in the European, Northern Europe, Central Europe, and that's because they do PSA testing. Australia, so their rate is high, whereas in Asia, some places like that, they don't do a lot of PSA testing, so their rate of getting prostate cancer is not high. And this is mortality, so likelihood of dying. So you see that in industrialized country, that heat goes down. So lots of guys are being diagnosed, but the rate of dying isn't very high. But if you look at this, you look down here at Western Africa and the Caribbean, they're hot. And despite the fact that if you get a closer view, if you look at the incidence of being diagnosed with prostate cancer in the islands is a lot less than it is in North America. But if you look at the rate of dying of the disease, it is way worse than it is in North America, suggesting that there's access issues, there's treatment issues, there may be attitude issues, but there's probably also a genetic reason that this is the case. And it's not just for prostate cancer, it's the same for breast cancer. This is kind of, you can almost overlay these other than ones pink. Is that there's a lot of rate of breast cancer in industrialized nations, in Canada, US. But if you look at the Caribbean, you get a less of a rate of developing breast cancer, but a higher rate of dying of it. And these two cancers are both very common. They both benefit from screening. So if you don't do screening, you're more likely to have advanced disease. And they are both linked genetically. So families that have lots of breast cancers will typically also have prostate cancers because there's probably a genetic link in a lot of those scenarios. The problem is if you look at all this data, most of us just view this kind of as the tip of the iceberg. Because the estimates of dying of these cancers in Jamaica, for example, are probably underestimated. There's just a lack of funding, infrastructure. There's not many registries. There's not a lot of kind of homegrown research going on. I have a couple of people that I've tried to collaborate over the years, both in Jamaica as well as the other islands. And it's a challenge. I mean, there's, and I make the joke and it's, kind of funny, not funny. It's, they don't even know how many people are in those countries. How the hell do you think we're going to know how many people had cancer, who admit they had cancer? The number of patients that I have from the islands that say that my dad had something, no idea what. There's a cultural taboo to discussing it. So I do think that those numbers that we have are probably an underestimate when it comes to those nations. Whereas, the data from the United States and Canada, because we have billing codes and all that data comes from, you can find out right now how many people are diagnosed with prostate cancer in Canada based on the fact that they go to a hospital and there's a billing code that gets associated with it. Whereas other countries don't have it that way. So I guess the main question is, and which I've kind of alluded to, why do Black men do worse than non-Blacks? A lot of it has to do with inequality, systemic racism, cultural issues. A lot of things have been, a lot of this data is from the US, and there's major financial issues there. There is a cultural issue with approaching, and I only say that having had lots of experience now talking at barbershops and churches, and there is and this is Black men telling me this, it's not me perceiving this, is that there is a cultural issue with having fingers up your bum and talking about prostate cancer. And the fact that, obviously a lot of this is linked to masculinity, to sexuality, and genetics. So there is data for all of these things. And these are probably all the reasons why Black men don't do as well as non-Black men. So looking at the non-genetic factors, I think are the predominant issue. I think the predominant reason Black men do worse are not genetic. Black men that have more advanced disease compared to non-Blacks, if you just like look at it, ignore color, ignore culture, ethnicity, those men have less access to screening and medical care because they come with more advanced disease. It's cost, it's education, it's the systemic racism, it's the lack of investigation. So these things all will skew it towards Black men come with more advanced disease than non-Black men. Black men are less likely to be treated aggressively. So if you look at, this is mostly data from the US, I suspect in Canada, it's maybe not as bad, but it ain't gonna be that much different, is that, for example, when guys have very high risk prostate cancer, even intermediate risk prostate cancer, the standard treatment is the addition of hormonal therapy to their treatment. Whereas if you look at in the US, for example, African-American men are much less likely to receive hormonal therapy in addition to their other treatments, even when they have really bad prostate cancers. And that is in part because of cost. Those drugs are very expensive. And if you don't have a drug plan, it's probably cost prohibitive. Those drugs in Canada, where we have caps, are about $1,600 every 3 months. And there's cultural. So because hormone therapy, invariably, there's a loss of sexual function, and that is a barrier in some cultures, particularly in the African-American culture, of accepting it as a treatment. Black men, and I'll show a little data about this, Black men view their disease as being less aggressive than non-Blacks. So they perceive that their disease isn't as bad as non-Black men. And that then leads to poor outcomes because they're less likely to take the disease seriously or be treated aggressively. That's education, it's cultural. Those are things that are very hard to approach, acknowledging that. And I've seen this in the last 10 years or so. The attitudes are changing for younger Black men compared to their older cohorts. There's more openness to talking. There's more accepting the consequences of therapy, the consequences of being screened and diagnosed. So these are changing, keeping in mind that when we give people data, it's based on stuff from 10, 15 years ago. You can't give data on what people are doing today. And the other thing is, if you look at when Black men are asked to consider things based on what they're going to consider for treatment, they're far more likely to consider the cost of the treatment, how long it's going to take, so how long are they going to be out of their normal routine, and how long it takes to recover. And these are all tied to financial issues, of course. They can't be away from work long. Maybe they have, they're the only income, maybe they have multiple jobs. I mean, so there's all these things that Black men are more likely to look at the things that have to do with financial issues when it comes to their cancer and make decisions based on that, other than non-Blacks, which are more likely to look at the disease issues, not cost. And this is just a couple of very brief examples of this. If you look at the approach to the disease. So if you look at non-Hispanic Blacks in this study, where they kind of differentiate between it, who prevent with advanced prostate cancer, so bad disease that if you know you don't treat it, they're going to be in trouble. They are much less likely to pursue aggressive treatment options. So they're more likely to take the thing that has the least amount of side effects, not the highest chance of being cured. This tied in in the last 7 years with all the big organizations initially telling doctors to not do PSA screening, is skewing that towards even worse outcomes, because more men now, less men are being diagnosed because they're not being diagnosed with lower grade disease, but they are being diagnosed with higher grade cancers. And then the Black men are less likely to go for aggressive treatment. So this has caused an unfortunate increase in the higher grade cancers, and that probably has a downstream effect, making even the outcomes worse because the disease is picked up later. And then perception. So what influences decisions? And this is the data kind of looking at everything of how people perceive their disease. So African men were, even when they had bad cancers, they were more likely to consider their cancer not aggressive when it was very high risk. So that's what the table is back here, down here. So if you ask an African American who had really bad prostate cancer, do they think it was aggressive? They were more likely to, more than 50% thought it would perceive it as being not aggressive, whereas that was only 24% in non-African Americans. And then if you ask guys perceptions of, was a cure important? Both, of course, said, yeah, cures are important. But again, the African American men were more likely to consider the cost of the treatment and the treatment time and recovery time is very important, where the non-African Americans didn't think that was important. Their importance was cure. It doesn't matter how much it's going to cost me, the cure. And that's, of course, a socioeconomic issue. It's easier to not worry about cost when you're not going to wipe out your family's money and worry about rent and food next month. And if you look at what we call multivariate analysis, that's where you take, so for example, the example I used before where higher education, so university is associated with breast cancer risk. That's because women that go to university have children later in life, they have less children, they're more likely to use the birth control pill. And those three things alone increase exposure of the breast to estrogen. And increased estrogen exposure to the breast increases the risk of breast cancer. Those are the reasons. The going to university is the thing that's associated. So in a multivariate analysis, what you do is you throw all those things together and you control for all of them. And what it would show is that the university thing is just associated. It's not the actual cause. The other things that come along are what drives that up. So if you look at these multivariate analysis, like all the different things that could influence why Black men do worse, perceived aggressiveness of the cancer, them perceiving their cancer as not being aggressive, was associated with them having less aggressive therapies and not doing as well. So that in itself, independent of everything else, independent of genetics, when it was found, just their perception of aggressiveness and cure were associated with receiving treatment, and therefore not receiving treatment, their outcomes aren't as good. Race itself, if you just put race into this model, wasn't associated. It was more about the perceptions of their disease and their acceptance of treatment. So in this study, you couldn't say it was just because someone was Black. It was what the people that were Black were more likely to do with their disease than the actual color of their skin. But there is data to the alternative, and that's why you can never look at one study and just say that's it, that's the stuff. And this is a big study that came out that kind of showed a bit of both. And it looked at 300,000 patients in this huge database, of which over 52,000 identified as Black race. It's a bit of a murky picture, just like white is murky, but that's kind of, it's a big data set. If you looked at men of Black race compared to the rest, they were 30% more likely to die of prostate cancer than non-Blacks. This is consistent with all the other things that we've kind of been looking at. Now, again, adjusting for all these non-biological differences, now this wouldn't have kind of people's perceptions. This would have socioeconomic class, whether they have private healthcare versus non-private healthcare, because it's the US, all those things that you can control for. There still was an increased risk of prostate cancer death in Black men, but it was only about 0.5%, which is significant because 10 years is not a long time for prostate cancer to die. So the fact that there were even more men just because of the color of their skin dying suggests that there's something more than just a lower socioeconomic or lack of access to care. And there's some studies that have shown that Black men that have low-risk prostate cancer, the type that you shouldn't die of, are more likely to die than non-Black men. Suggestive, again, of all these other factors we've kind of been talking about, but also that there might be a inherent susceptibility to more aggressive disease. So maybe a low-risk prostate cancer in a Black man is not really the same as a non-Black. The issue, though, is that the data is very murky. Some studies show that there is an increased risk, some studies don't. And there are what we call confounders in these databases. Confounders means it's something that you don't know, you don't have in here that's influencing the data. And that could be Attitudes could be one of them, geographical reasons and regions. In some places, their attitudes are better than the others, but they lump them together. So the problem is with these big databases and these big population studies that you never really know if what you're looking at is true. These are just hypothesis generating. They're giving you ideas of what might be going on. It's not hard science like we see with some of our molecular stuff. But I'll tell you what, it's not the bun and cheese. So, I mean, I think that a lot of people, when we talk to people from other parts of the world, they're always just like, oh, it's this, it's that, it must be, you know, they have lots of salted fish or they have whatever, you know, those things where when a Black man leaves Western Africa and moves to London, England, his kids who will have adopted an English diet, an English environment, will have a higher risk of getting prostate cancer and dying of prostate cancer than the white guy beside him. So it's not behavioral or food patterns, because that risk follows these guys everywhere around the world. So genetics, some of it very well could be genetics. I'm not going to bore you with this kind of stuff because I don't think it's as important as the other things I've spoken about. But there are several studies that show if you look at several genes and you compare those genes that we know increase the risk of getting bad prostate cancer in Black men versus non-Black men, we see these genes sometimes are what we call overexpressed. They're working too hard compared to the non-Black, and they are associated with an increased risk of failing treatment. So this is a study that said that if you had this panel of genes that were overactive, you were less likely to be cured from the same treatment. And this was found more in Black men than in white men. That can't be explained by someone's attitudes towards their disease. And if you look at the whole genome, you take all of the DNA and look at every little mistake. You can measure and compare between people, how many mistakes in general. I'm not talking about a specific mistake, but this guy has 1 million mistakes and this one has 100,000 mistakes. And if you look at this, what they found was that there are more mutations in general in the tumors of Black men compared to Caucasian. Here they used a big European cohort just because that DNA was available. So in general, there's just more mutations. Not specific ones, but just there seems to be more in Black men. So maybe there are some, one of the predispositions, one of the things that can increase risk getting is that we call DNA instability. The DNA is just not as stable. It makes more mutations than the average non-Black person, and that will increase the risk of having cancer because you develop more of these mistakes. And then just eventually randomly, there's a higher chance of getting cancer. And that could also contribute to aggressive disease. So for example, the reason why so we have BRCA2, the BRCA2 gene, the one that Angelina Jolie has. We know if men have that gene and they get prostate cancer, half of those guys die within 5 years. At least that's the older data. I don't think it's bad now because we're much better identifying them. But that's a real cancer. So, and the reason is that I don't think those guys develop prostate cancer at a higher rate. I think they get prostate cancer like everybody else. But BRCA2, as you might recall me telling you, is a gene that's involved in repairing DNA. So if you get a prostate cancer, it slowly grows along. All you need is one of those cells to get a mistake in the other copy of BRCA2, and now that cell, that individual cell, is very inefficient at repairing DNA. So it might develop a whole bunch of other mutations along the way. So that's what we call a mutator phenotype. And it may be that Black men, and this would be Black women as well, there'd be no reason to think otherwise. Maybe why Black women have higher rates of breast cancer, have something that makes them this mutator phenotype. They develop more mutations. So not only do they develop prostate cancer more, but it may not be that they develop it more, it's just that they're more likely to be diagnosed, because their prostate cancer develops at the natural stage as everybody else's, will eventually become aggressive quicker than the guy that doesn't have this genetic problem, this instability. So that's some very interesting data that kind of maybe is speaking to why we're seeing more aggressive disease, ignoring all the socioeconomic and perception and lack of access issues that are a real problem. And this is why I say that I do think there's a genetic. So this is a family tree, and I don't know if any of you know how to read this, but squares are boys and circles are girls. And when people are linked together, so these people are married, these are their 5 children. And this woman married this man and had a whole whack of kids. And this guy's had a whole bunch of kids with a bunch of different women. So black, when it's colored in, that means that person has whatever disease you're making this chart on. In this case, it is cancer. And a line through it means that person died of that disease. And you usually put down what the cancer is underneath. So for example, this man, his wife died of myeloma, and he had prostate cancer. He ended up having a second wife. He died of prostate cancer. So that's what this means. Now, this is a family in my program. So these people had 7 kids, 6 of which were boys, and all 6 of them got prostate cancer from the age of 46 to 53, which is very early onset. So this is not perception. This is not these guys not going to see doctors. This is not systemic racism. This is not bun and cheese. This is genetic. You cannot have that many brothers all with prostate cancer at 20 years younger than we normally see it, not know that it's something they inherited from dad or mom. And that's why we just don't know what it is. And that's why kind of this research is important. Here's another family, again, a family tree. Here's a father who had prostate cancer at 60, colon cancer at 60. Mother had breast cancer at 77. She lived to 93. She's still 93. She's not dead yet. There's no X to her. So they, again, had three of the 4 sons all had very early onset prostate cancer. These are family trees where this is genetic. You don't have that many people in the family with early onset prostate cancer without it being something that is genetic. Now, if they all smoked like chimneys and they all got lung cancer, you'd say, okay, well, they're all smoking and that's the deal. But prostate cancer doesn't have any of those environmental associations that we know of. So that's some of the things that we are doing at Sunnybrook in collaboration with other groups. We're looking at, I take men that have both a personal family history, so they have prostate cancer themselves, and they have someone else in their family that has prostate cancer, but they don't have one of these crazy syndromes where there's like mother got breast cancer, sister got ovarian. We do a gene panel on them to see whether or not we can determine what the genetic link is. I suspect we're not going to find it because we're looking at the wrong genes. We're looking at so I run the active surveillance program at Sunnybrook. We have about 600 men. We have all of their DNA banked from their blood. And now we're going back and looking at their genetic signature, looking at these mutations in all these genes to see whether or not we could predict. Now, there are a relatively large cohort of men from the Caribbean or from Western Africa in our group, because Toronto's obviously got a lot of people from that population who do go into our program on active surveillance. So we're able to tease out that data. Those are ongoing studies. We're also looking at how do these cancers become aggressive. So we can take someone that has prostate removed, and we take out some of the normal cells, and we take out some of the normal prostate cancer, and then we take out some of the really aggressive disease, and we compare the genes to all of them to see whether could you find what genetic changes made that aggressive. That will allow us to go back and screen people beforehand to see who has, how did someone get such a bad disease? Why do Black men get such bad disease? Maybe we can find the initial genetic precursors that make it there and then use it as a screening tool up front. There's a barrier though. So research specific to Black men outside of these big population studies is very challenging. So I've had this program open for, loosely for 10 years, probably officially for 7 or 8. There's a lot of difficulty with engagement. I'm preaching to the choir. You guys are all here, so I know that you're engaged, but the number of talks I give to churches and barbershops and local groups and everyone means well and they get good information. I'm glad that we passed that on, but getting people actually to come in to give blood for the biobank to be involved in the program, there is a lack of engagement. And I understand why. There's years and years of mistrust, and it's not an easy thing to come over, and it's not an easy thing to talk about, but it is a barrier. And that's because of lack of awareness of the risk. That's why things like this are so important. Misunderstanding of screening and treatment. Why get screened? You don't want to be diagnosed. I don't want to be treated. You hear all the horror stories of people being treated. Lack of trust in the medical system, historic, systemic, current racism. lack of trusting relationship with healthcare professionals. That's part of racism, of course. Just never adopted that relationship with someone and trust what they say. And then another one, as I talked about earlier, is that prostate cancer screening and its resultant treatment, if needed, is really a threat to masculinity. And that's because we all equate treatment of prostate cancers with lack of erectile function. And in some cases, it's true. But I tell all my guys that if you get your disease picked up early enough, you're far more likely to have good erections and a good sexual life compared to having worse disease, because the odds of having good function as the treatment has to be ramped up goes down quite significantly. So you'd much rather find out early and deal with it earlier, because then you're far less likely to have an impact on all quality of life, urinary issues, bowel issues, and sexual function. And I tell guys, you know, like, and I apologize, I've used this slide for years and I keep recycling it, but, you know, guys are like ostriches. You know, we're the worst patients. We don't go to the doctor. We don't get our blood test done. You know, unless your like arm is falling off, you're just like, eh, that's okay. So, but the problem is that, you know, tiger's going to get you. If you're in a high risk group with a high risk of getting it, not getting tested is not going to help you from the tiger coming. It's going to come. And by the time it gets to you, you're screwed. Whereas if you get tested, you can maybe see it from afar and deal with it sooner. Just to summarize it, you know, so I'm a molecular biologist. We spend all this time in looking at how does this protein enter with that protein, how does repair DNA. This is the pathway involved in DNA repair that I use because radiation causes DNA damage. That's how we kill cancers. So this is some data from studies we've done where we actually can look at individual, like little breaks in the DNA and actually map it out in individual cells to see, was there increased damage? Is there decreased damage? Is these BRCA genes, do they make a difference? Does that help influence or increase the risk of getting cancer? We can do these heat maps. So these are all individual people with all these different, we call microRNAs, little snippets of RNA we can pick, which is a type of genetic material. We can pick up in the urine and then identify, hey, whose cancer is getting worse? Whose isn't getting worse? Can we use this as a tool to monitor cancers? And a lot of research we do is with MRIs, really fancy imaging. Can we use that as a tool to screen guys? It's dramatically changed what we do with that, with surveillance. And at Sunnybrook, we have something called an MRI Linac, which is a radiation machine with an MRI built into it. So you can watch in real time, treating something to really minimize risk, dial up the dose. And now we're getting away with very minimal risk of treating prostate cancer with radiotherapy because of technology like this. And I run one of the research programs looking at integrating this into care. These super, super high doses of radiation with nothing going anywhere else. So this is great. This is all crazy stuff. And it's good. And people like to talk about it. We like to get up here and pontificate on our pulpit and see how great we are. But the truth is that, you know, how do we really save lives? In the majority of cases, it's awareness. And that's the whole thing, particularly with men, is that, you know, this is an advertisement for colon cancer screening. But, you know, men die because of stubbornness. We don't get colonoscopies. We don't get PSA tests. You know, so I think that you just have to you get the PSA test. You get the DRE, you get the digital record examination. Nobody likes it. We don't like doing it, but you get it done because these are two things that are relatively simple things to minimize the chance that you have a worse disease. So all that research we do, all that stuff that I've done and we talk about and I'm doing, there's no doubt we save more lives just by raising awareness to actually get screened and find earlier, because that's going to save more lives than my crazy MRI machine that can do things within a millimeter. So the take-home messages are, you can't change your genes yet, maybe someday. Get screened. With men, that's a digital rectal examination. The only reason to do it is if you don't have a rectum. PSA screening, there is controversy. PSA screening can overdiagnose people, and overdiagnosis isn't the problem. Overtreatment is the problem. I think it's clear for those with a family history, those of African or Caribbean ancestry, PSA testing is needed because we know the risk of getting disease is higher. And if you get the disease, the outcomes are worse. For women, it's mammograms, self-examination, pap smears for cervical cancer. Just avoid this guy. He's sham. Those are bona fide, easy ways to detect disease early. And we'll keep looking for the genes, right? Because ideally you would identify people way ahead of time and then enable us to tailor care in regards to how people are. So just a brief acknowledgement. I have a great crew at Sunnybrook. Justin Lawrence is the genetic counselor that works with me, is my co-partner in this. Couldn't do it without him. We have lots of scientists, pathologists, radiologists on board. It's a collaboration across the world. Thank you very much. I don't know if we're doing questions now, but I'm happy to if that's how it works.
Yeah, thank you very, very much, Dr. Vesprini. Really appreciate that. It was really an excellent presentation. So there are a number of questions, but what I want to do is bring in the panel into this. So he is going through his situation right now. Anthony, you want to talk a little bit about your situation, and then we'll go to the rest.
Sure. So my name is Anthony Henry, and I joined the Walnut Foundation in 2010. My father was diagnosed with prostate cancer at 64. Unfortunately for him, it was a late diagnosis, but he stuck around for another 4 years. He died at 68. My brother was diagnosed at about 57. My father, so my uncle, my father's younger brother, he also was diagnosed after 65. And so they did the surgery. They did the surgery. For myself, I was diagnosed at age 54. Part of the issue with mine, of course, when the situation happened with my father, we were shocked, really, because he was a regular at the doctor's, very compliant, but yet he ended up with prostate cancer, and caught at that late stage as well. So for us, it was a wake-up call, and so for myself and my brother, we started getting tested. So when I say tested, getting a PSA done at myself at age 40. At 54, I was diagnosed, but my cancer was deemed to be of a non-aggressive nature. So I was referred to do active surveillance. And I've been on active surveillance since 2015, so 6 years, I guess, now. I'm currently on that path. What I would suggest, and certainly agree with Dr. Vesprini, is that it's important to get that PSA done early, get that baseline PSA so you know what your numbers are. As I said, I started monitoring at age 40. My PSA at that time was about 0.79 or something like that, and I followed it every year since then. When I say active surveillance, what I mean is that I haven't had any active intervention, so not surgery, not radiation, anything like that. I'm just being monitored by my medical team. So I get a PSA done every 6 months, and if necessary, I follow up with my my oncologist. And that's kind of where I'm at right now. What I would say as well is it's important to follow up with your medical team, right? I would also implore and encourage everyone to participate in the studies, the kind of things that Dr. Vesprini is doing at Sunnybrook. For myself as well, I mean, I have participated, and that has kind of informed how I've been working and dealing with my cancer. For example, I know that I'm not positive for the BRCA gene, right? So, I mean, that's an indicator from what I understand, that if you are on active surveillance, but you're positive for that gene, then you might want to reconsider that approach. So that's one thing. I would say it's important to stay current, keep your knowledge base as current as possible. When I was diagnosed, the only thing I knew was surgery, nothing else. And so when my team recommended active surveillance, there was shock, consternation, hostility, even when I decided to follow that recommendation and do active surveillance. So knowing what's happening currently in the medical field with respect to prostate cancer, and specifically how it relates to me, it has been very important and instructive in terms of how I deal with my situation. So I think it's important to stay current. Yes, participate in trials, and yes, follow the science, because maybe if I didn't follow the science in terms of where it's at and specific to me, then I would have listened to the stories that says active surveillance is not for Black men. And there's that controversy as well. But Dr. Vesprini might want to speak to that later at some point, if we have time. Thank you.
Thanks, Anthony.
And I'm happy to participate in these kind of forums and share my experience, because I think we learn and grow and understand better, from everything that's being said here tonight and what each member on the panel can share. Thanks.
Okay, thanks, Anthony. Simon, Samuel, just give a brief of your situation.
Yeah, thank you, Ken. My name is Simon Samuel, the co-founder of the Walnut Foundation, and I also was diagnosed with prostate cancer at the age of 50. And at the age of 50, you have this, you get this message from your doctor that he wants to see you, second opinion, and then you go through all the tests, and then you became, positive. And that's one of the things that, if the dirt could open, then you sink in, and then you're hoping that you wouldn't get up, because first thing that go through your mind, I got prostate cancer, and how long do I have to live? So that's one of the scariest things, that being diagnosed with prostate cancer. But the thing is, my co-founder, which is Dr. Winston Isaac, always said that early diagnosis would save life, and like Dr. Vesprini just elaborate a lot on that. But in 2007, I met my partner, Dr. Winston Isaac, and he also a prostate cancer survivor, and we decided to start this foundation. And why we decided to start this foundation is because there was no Black organization to support Black men with prostate cancer. And that gave us the zeal and the desire to do this. I'm very thrilled today. I'm very happy to see that where we come from 2007 to up to this point. And one of the things that we spoke about at the early beginning of starting this foundation is how we can reach the Caribbean, men in the Caribbean, and men from Africa also. And today, I sit here and with goosebumps on my skin, and saying that after the many years we've been trying to bridge this gap, and here we are today doing that for our African brothers and sisters, and also the Caribbean people. I'm going to just do briefly. I'm going to just leave a few words with you, and like Dr. Vesprini said, prostate cancer is prevalent in the Black community. There is no doubt. He elaborated on that very much. But what I want to leave for the men here in this forum here, I wanted to just take a page from your wives or your daughters or the female in your family. Whenever the female have to go to the doctor to do the pap smear or anything like to do the test, they have no hiccups. And one thing is, as men, we tend to run away from doing this test. The digital examination is very, very important. And I hope, when we all leave here, when the men leave here, they will get a full education about how they should take care of themselves and to prevent any further activities in terms of dying of prostate cancer. And again, I would repeat that my partner always said, men do not have to die from prostate cancer.
Okay.
What we do, we ask you to know your numbers, and Anthony said that. So we encourage you. Thank you so much for inviting us here, and we hope that you can we can continue this relationship. Thank you.
Thank you. And finally, just Winston Class, briefly about yourself.
Okay, I've got a bit of the ostrich in me. I'm not terribly health conscious, average, not too bad. My story is a good story, and that's because I caught my cancer early. I stumbled into an annual physical examination with my doctor, and it included a DRE. And in 1996, he found a raw spot, led to a PSA test and a biopsy, which was positive. My PSA was elevated at about 10, but he thought we should do some watchful waiting. And it stayed flat for about a year, and then it started to rise again, and I had to select a treatment. I selected surgery because I just wanted the cancer out. It has been good until now. I've had minimal side effects in terms of incontinence, and my sexual function was preserved, all because I caught it early. There's a history of prostate cancer in my family, my dad and my brother, my younger brother. So what I want to leave with you, if you're destined to be diagnosed with prostate cancer, ensure as much as possible that you catch it early, as everybody else is saying. And one more thing, manage your doctor. Most doctors go along with this and they believe in the PSA test, but you could stumble onto a doctor that is pushing back on aggressive PSA testing. You stand your ground and you make damn sure that that doctor follows through on your PSA test. Because I've known of cases in which doctors were a bit lax, and it led to some very bad consequences for the patient. Thank you.
Thank you. So, guys, I'm going to read out the questions that have been put into the chat, and I think a lot of them are for Dr. Vesperini, but if any of one of the guys want to jump in. The first one is, can prostate cancer metastasize to other parts of the body?
Yeah, so early prostate cancer, like Anthony has, cannot. And that's the controversy of calling that cancer. There's a lot of discussion now that we should be calling early prostate cancer, so the old Gleason 6, what we now call grade group 1, it should not be called a cancer because it does not have the ability to metastasize. It does have the ability to change into a higher grade cancer that then should be treated. High grade, very high grade prostate cancers that we do find once in a while now, because there's less and less PSA screening, does have the ability to metastasize. And that can go to the common spots that it goes to is the bone, the lymph nodes, rarely the liver and places like that. It predominantly is a disease that goes to bones. But like I said, low risk prostate cancer it's never been shown to metastasize. But a man with low risk prostate cancer can then develop a higher grade cancer that, if not found early or treated early enough, can eventually go. So in our active surveillance program, so we have over 1,500 men, some of which watched since the mid-90s, with low-grade prostate cancer. The chance of dying of the disease within 15 years is less than 1%, because we watch the guys, and if it changes, we treat them. And that's kind of that's the goal of surveillance. So it can metastasize. Fortunately, picked up early, that's very rare.
Okay, the next one is, how do you control your PSA level? The number fluctuates and all the doctor says it's high or low or normal. How do we keep it normal? What are the causes of it going high?
But you don't, there's nothing you do to keep it normal. It is just a concentration of that protein in your blood. It will fluctuate from day to day based on many different things. How long you held your bladder. Did you ejaculate in the last day or two? Did you ride a bike? So these things all can make it go up and down, but those are Those aren't the important thing for people to know is that there is no reason to overreact to any PSA value. So if a guy has a PSA that's normally 1 and he comes in the next time it's 2, that there's no reason to overreact because we know PSA fluctuates on a day-to-day basis. There are some things we can do to stop that. We can give people drugs to make the PSA level off, but it doesn't stop the chance that the person has prostate cancer and they have side effects. So the goal of a physician, of any medical person, is to make sure that people understand that the PSA is just a measure of how much prostate there is, and it goes up and down, and it's the trend over time that's important, not the individual values.
Okay. Is the PSA prostate cancer cell detectable in normal blood work? If yes, are medical professionals allowed to say?
So it has to be specifically looked for. So that's a common thing. So for example, I get asked this question at least once a month. People ask me because I do their PSA test, their hormone levels are in that. They're like, what's my blood type? So I mean, every blood test you have to specifically ask for it because they're very specific assay. So yes, PSA is very easily detected in the blood, but if the doctor doesn't check off the little thing saying PSA, it won't be done.
Yeah, there are reports that increased sexual activities reduce the risk of prostate cancer. Is there any truth to this, or scientific evidence for this?
So yes, there is a couple of studies that show that if you compare men that ejaculate a lot before age 40 compared to those that don't, there is less prostate cancer risk in the guys that ejaculate a lot. 2 caveats to that. 1, it's before the age of 40. And I didn't see that many guys on this list that are less than 40. There were a couple guys that you guys from Ionsville, you age really well. So there might be a guy that looks 30, he's probably 70. But I do tell my guys, hey, look, just because there's no evidence that it doesn't help after age of 40 doesn't mean it doesn't protect. For example, before they measured Mount Everest, it was the highest mountain on the planet. There was no evidence for it yet. So I do tell my guys, go nuts. I think that if it protects before the age of 40, it probably protects after as well. But the only thing for the women, which they can come back on, is that it didn't say sex. It said ejaculate.
Yeah.
So you don't need a partner for that. But kidding aside, sex is a very healthy thing. There's certainly no detriment to it. There's that evidence to suggest that it might be protective. So I think it's a good thing to do.
Yeah. So this next question, you addressed it, but I'll ask it again. What is PSA and PSA testing? I think you did.
Yeah. So PSA is prostate specific antigen. So what it is it literally is that enzyme that the only thing prostate does is make PSA. And it's an enzyme that is ejected in a man's ejaculate, and it allows sperm to swim freely through the ejaculate so that it can go up into the cervix, and then if there's an egg there, impregnate the egg. So that's the only thing it does. Now, it is always found in the bloodstream because, again, all the things in our body can be found in the bloodstream. And so if the PSA is higher, it either means the prostate was aggravated or inflamed, and so that a little bit more got pushed in. And that's what happens after you ejaculate. For a couple of days, it's high. If you have a bladder infection, it goes really high, or you have more prostate. So the level of PSA is relatively indicative of how much prostate you have. So as the PSA goes up in men as they get older, which is natural, that's because the guy's prostate's getting bigger. And that's why as you get older, you pee more often at night, you spray more when you pee, the nice stream goes away, you dribble a bit afterwards. Those are all signs of an old man's prostate. That's natural. And that's why so my PSA, because I'm so young, is probably about 1. Whereas in about 20 or 30 years, God willing I live that long, it might be 4, because my prostate just naturally got that bigger. So that's the whole thing. It's not a one thing. It's not like, for example, there's some cancer markers, something called CA19-9, which is the marker we use for pancreatic cancer. If you do that test in someone and that value is 1,000, they have pancreatic cancer. There's nothing else. Whereas if a guy has, and there's a question here I saw a little later, if there's a guy here that has a PSA of 10, which is pretty high, it doesn't mean he has prostate cancer. He just might have a big honker of a gland. So that's where, that's where the nuance of what the score is and what the person's history is important.
What are the signs that one has prostate cancer in the early stages?
There are no signs for early stage prostate cancer. And that's why screening is so important. And that's a common thing that we hear is guys say, I feel great, doc. I got nothing. It's like, if you're waiting to feel something for prostate cancer, it's too late. So screening is absolutely, you cannot detect early prostate cancer without screening. There's zero signs. By the time someone has something that they can feel, either pain, pressure, bladder issues, that would be a very aggressive prostate cancer, which thankfully we don't see that often anymore.
So this question is for Anthony. Has your PSA reduced from 0.79 over the years, or has it been stable or gradually increasing? What are the doctors saying about the chances of PSA levels in the future?
So in my case, I think I started out at about 0.79 at age 40. It has gradually increased over the years, but it has also reversed. So I think back in 2008, I had a scare. And at that time, what had happened was I went in to see my doctor, did a PSA, and then, did my physical exam. So he did a digital exam. I left there and walked across the street to the lab, do a PSA test. And what you know, it came back much higher than the year before. So about 1.61 higher than the year before. I was referred to a urologist. We did a retest, but when we did the retest, it was low again. So nothing was done there, and so I think they attributed that to the fact that any disturbance of the prostate can also cause the PSA to spike. Fast forward from say 2008 to 2015. Had another major increase. I think the difference from year over year was about 2.61. So that's when I actually went to do, referred again to a urologist, and that's when I actually did the biopsy. And the biopsy actually confirmed that there was, in fact, some cancer cells there. 2 out of 12 cores, I think, was positive. Over the years since then, it's gradually increased, but I'm doing a PSA every 6 months, so sometimes it goes up and then it falls back again, and I've been on that kind of path since. I imagine over time it'll probably increase, but we'll see. I'm basically a work in progress as prostate cancer goes.
Okay, thanks, Anthony. So there's another question. We also know from literature that a high or increasing PSA does not necessarily mean cancer. On the other hand, a lower PSA reading can reflect otherwise. Isn't that a medical or psychological dilemma?
Yeah, I mean, it's true. I use this analogy all the time. Is screening tools are much like the nets we use to catch tuna. So if you want to have a screening tool that finds every cancer, you're going to find a whole bunch of cancers that you don't know, or tell people they have cancer that don't. It's just like if you want to catch every tuna, you're going to kill a whack of dolphins. Mm-hmm. So they make nets so that dolphins can get free, but a lot of tuna get free as well. So screening tools will miss some because they don't want to overcall it. And that's, most screening tests are like that. So yes, you can have a low PSA and still have prostate cancer, which is why the digital rectal examination is still needed. So I got in a somewhat heated Twitter battle with family doctors a few years ago because they were going on this diatribe that they should stop telling family doctors to do the digital rectal examination because it was a waste of time and there was no evidence it helped people. So I said to them that they're being crazy, that it's an easy test. It costs no money, costs both the operator and the receiver a little bit of dignity. but it's a reasonable thing. If you want to argue not doing PSA tests, that is reasonable. And then they got mad at me, told me I was being condescending, which I kind of was. And then they started quoting me actually some of my own papers. They said, you should read this paper about active surveillance. And that's how I decided I had to get off that battle. But the point being is that the person's life you save as a family doctor is the person where you put their finger up there and you feel something, but he has a normal PSA. That is bad prostate cancer. And I see it. That is the few guys that come in with these bad cancers. Their PSA is completely normal, but no one's put a finger up their bum for years because they're, oh, your PSA is 2, it's fine. So that's where the DRE is needed. And yes, a high PSA, like I said before, does not mean you have prostate cancer by any stretch of the imagination. And that's why all these enhanced tools that we have with urine tests and MRIs become more and more important.
This one, no, we get a lot from the Walnut Foundation. What PSA number should one be worried about? I'm assuming that age will be a factor on this as well.
It's part age related, part how big is your prostate, which is age related, and what is your PSA doing compared to previous. So, for example, again, I'm a little younger than Ken, and if my PSA was 10. That you'd have to double check that. Whereas if Ken's was 10, it'd still be high. You'd want to double check it, but you'd be less worried because, you know, a man that's 10 years older than me is going to have a PSA that is higher. So that's what it was. And for example, and the other thing is that we have a whole whack of guys in our active surveillance program whose PSA was 8. And I saw a guy last week, 2 weeks ago, where his PSA is like 7 or 8, which is high, but his prostate is the size of a grapefruit. And they biopsied him, they found low-grade prostate cancer. Now he's on surveillance with me. But the truth is that his PSA of 8 is low. For a prostate that big, his PSA should be 14. So, I mean, it's a little bit of knowing what the prostate is and the age, but the age is the main thing that we use because usually younger men have smaller prostates and older men have bigger prostates. The other thing is something called the free to total ratio. It's a separate part of the PSA test that we should be using to screen. When that free to total ratio is low, it's more likely to be prostate cancer compared to when it's high. And that's a screening tool that should be used because it helps determine what PSAs are high just because a guy has a big gland versus which are high that may be because of prostate cancer.
Would it be a good idea to ask your family doctor to check your PSA every time you go for a blood test during medical checkup? Yes.
Yes. Yeah. I think that's
obvious.
We would recommend once a year.
Yeah. So how do you know for sure that your PSA value is prostate positive? Secondly, how do people have a PSA value of 0 or even negative?
So yeah, so you don't know if the PSA is high because you have prostate cancer, and more importantly, you don't know if it's high because you have prostate cancer that you need to know about or at least treat, and you don't need it. That's the controversy of PSA test. So a PSA test is a tool to screen to see what are the odds someone has prostate cancer, and then other tests are needed. Unfortunately, it still ends up being a biopsy. That's whether you figure out for sure whether or not someone has prostate cancer. People can have a PSA of 0. So women have PSAs of 0 because they don't have a prostate. And if men have had surgery and they're cured, their PSA is 0. And very rarely after radiation, men will have a PSA of 0. Most men after radiation will still have a detectable PSA because they still have a prostate. So any man that has a prostate that hasn't been treated will have a detectable PSA.
How frequent it is recommended to perform a PSA? That annual?
Yeah, annual. I mean, I think there's discussion about high-risk men to start considering earlier at 40 or 45, more as a baseline. And then they do it once every 2 years. But yeah, I think annually is a reasonable thing. I think any more than that is, unless you have prostate cancer, is not of value. But so the recommendation is still once a year.
Yeah. Is a second opinion possible in Canada? This person said after biopsy was diagnosed in December 2018 at age 37. He's on active surveillance as well. His PSA has been 2.8 in the last year, which is the last reading, with the last reading last month. Are you allowed to answer that?
Yeah, oh no, yeah, there's no rules against second opinions by any stretch of the imagination. We have a universal healthcare. You may have physicians decline that, so the physicians can decline doing the second opinion. I tend to accept them all because I think it helps people with their decision making, even when I think that what's going on is exactly what I do. I think that that's of value. I do think that the pandemic and the virtual medicine in Zoom is going to open up the ability for people to get second opinions virtually without having to travel and spend all the money, which is amazing. So I see patients now from all over Ontario. It's easy as hell. So I mean, I think, but you got to keep in mind that physicians are autonomous. We don't need to give you an opinion. We could say, this guy busted my chops. He's got an opinion already. Why does he want to see me? So you might get resistance. Some centers will decline second opinions on general because their doctors are way too busy. But yeah, you can for sure. It's not like in the US where there's these rules about funding and things like that.
This one's probably going to be a last one. I agree with the necessity for screening, but I'm not sure I agree with the analogy with the tuna nets, because the test is often used to generate the fear of God without nuance.
It's true. Well, I mean, the dolphin's probably pretty damn scared when they're in that net. But no, the point is that there's always going to be what we call false negatives. So something you think is negative but isn't, and false positives. Something you think is positive and isn't. And that, like, there is no perfect screening test for cancers. And again, everything starts to get a little bit better. We add this to the test, and it gets a little bit better. So you add an MRI of the prostate to the PSA, and you get a better test because you're less likely to diagnose someone with a cancer that doesn't need to be diagnosed. But yes, it is not quite like the tuna.
So those are all the questions. How are you doing for time, Dr. Vesprini?
Oh, I'm fine.
Fine.
I'm happy to keep answering if you guys have time. It's up to you guys.
We have a few more in the chat.
There are more in the chat?
If you look at after the nuance one, there's another one. Is prostate cancer prevalent in certain races?
Oh,
If so, which race
what
is
the
more
whole, yeah, I skipped over that one because this was the whole presentation was about, is that
okay.
When you did that slide at the beginning, is prostate cancer more prevalent in certain races? Yes.
Yeah, and that's, like I said, it could be genetic, it could be environment, it could be genetic, could be where they live, but it's probably a little bit of everything.
Okay. Those are all for the questions. I wanted to spend 2 minutes and do a plug for a program that we're involved with that helps Black men with prostate cancer. So I'm going to share my presentation. 1 sec. I'll make sure that my computer doesn't crash this time. 1 sec. So what I'm about to share is something called the True North Peer Navigation, which is a virtual support for men with prostate cancer. As Simon alluded to, when you sit in the doctor's office or urologist's office and he said you've got prostate cancer, I think what we found is a lot of men have told us that's the last thing they hear. Nothing else matters at that point because they're going to this whole thing of shock that I've got prostate cancer. So we've worked with Princess Margaret Cancer Center. It's been supported by Movember to create what we call a peer navigation program for supported men. So we found that men need help. To actually go at it alone in life, it's even more dangerous. So as Dr. Vesprini said, 1 in 9 Canadian men will be diagnosed with prostate cancer. So while the treatment is highly effective, there are common issues that are experienced as a result of treatment. There's urinary and bowel side effects from radiation and from surgery. There's changes in sexuality. As Dr. Vesprini had said, there is changes in erections. There's emotional distress, the fact that one has cancer, this fear of the cancer recurring. So a lot of men said that there are gaps in care and lack of access to adequate information, because you see a doctor, urologist every 6 months, but there's nothing in between in terms of supporting men. And that's why, and the same thing goes to family caregivers as well. So when you have your prostate cancer treatment, the person supporting you is normally a wife or a family member who've got to do everything for you. Some of it is very embarrassing, and they already take care of your entire physical care after treatment. So they experience distress as well. They experience worry about the patient. The family worries whether the person is going to die. So it creates a lot of stress within the family. So they need information as well to help them better take care of their husbands, their brothers, their sons. So this is the reason why we created this True North peer navigation program. And what the bottom line is men helping men who've been diagnosed, who've gone through the treatment before, helping men who are now going through the treatment. So it connects you with someone who experienced prostate cancer and is trained to support you. So for example, if you're going to have a radiation or you're going through radiation, it connects you with someone who's already been through radiation, who knows what the side effects are, and actually can help you, support you through this. This was developed by scientists like Dr. Vesprini and clinicians in partnerships with patients and families. And the participants so far have experienced significant benefits in this program. One thing to point out that this program is very private. It's not a group situation. It's a one-on-one that you speak to the person online or call them on the phone, because people need help. And both Anthony and I are a big part of this program. You know, we get calls from men saying, you know, I've just finished my surgery and I'm experiencing these things. What do I do? And we help them through their process. So how it works, we sign up on a website. You sign up on a website, peernavigation.truenorth.ca. There's a few questions to be answered, and then you get matched with a navigator with the relevant experience. For example, someone going through active surveillance, radiation, surgery. And then you get personalized information and support by chatting online, phone, or video, or meeting in person. The important thing is, and we know that a lot of Black men don't like, you know, to share their information publicly. This is all private. It's one-on-one, and only you and that person know what's going on. So this is the program, the test that we did. There were 50 patients from British Columbia and Ontario. The Princess Margaret Cancer Center and the BC Cancer Agency in Vancouver took part in this first part of it. So this is what they said. They were very satisfied. 8.5 out of 10 was the satisfaction rating on this particular program. And they experienced significant benefits. They talk about quality of life, you know, having to help someone through things like incontinence, or the fact that, you know, they've lost a lot of erection, and we help them out with that. Information and support, we provide them with information. We don't provide medical information, but we provide information to them. They've been able to manage their own health, and there's less fear of recurrence because they're now feeling comfortable. And their greater needs are met for both the spouse and for the person experiencing prostate cancer. So it filled a gap in healthcare, because normally you're going to see a urologist every 6 months, but incontinence and loss of sexual activity happens every day. So they need some people to talk to. So it reduced isolation and fostered hope and confidence in the men. And this is what we found. The navigators were knowledgeable, honest, empathetic, and distant from their social network. So, you know, we got some comments back from people saying they were really good. Even the family caregiver that we had within the program really gave us some very positive, because it helped them as well. So for men who are going through treatment of prostate cancer, you sign up with the True North Peer Navigation Program. You talk to someone about your real experience. You feel comfortable discussing symptoms and side effects. You don't have to wait until you see a urologist. You can discuss your symptoms. People share their information, what they went through, and it makes people feel comfortable with it. So please, if you need information, you can email us at info@thewalnut.foundation or Dr. Jackie Bender at uhnresearch.ca. So that's a really good program that's been implemented to help men journey through this whole prostate cancer. Because for Black men, it's a lonely journey and you really need help in this. And this has worked excellent for our community. So that's my plug for the True North Peer Navigation Program. If there are any questions about it, you can plug it into the chat. If not, Bio, do you have any last words do you want to leave with everyone?
Yeah, Yinka needs to has some announcements to make.
Sure.
Yinka, are you there?
Yes, I'm here.
Did you want me to share your presentation?
Yes, you can. Okay, let me do it. Good evening, everyone.
Hello.
My name is Yinka Oladile. I'm also with the African Cancer Support Group. I'm actually the executive director. And like my husband said earlier, we provide support for all patients and caregivers, and it is for all types of cancer. You know, we provide emotional, psychological, and sometimes material support. We all know that Black people don't like to talk about cancer. Well, know that the Walnut Foundation and the ACSG, we are all here to help you navigate your journey. We are not-for-profits, and your donations will help us bring more programs in the future. I'm talking about program, as we have done today for men. In about 2 weeks, we have a program for women because October is the Breast Cancer Awareness Month. As you are here tonight, we'll be sending you the information. Please share it with your wife and also with your adults, ladies. I don't know, for some reason, women also don't like to go for testing. You realize that people get diagnosed maybe when it is almost already late. We'll share the information. We also have the doctor that is coming. She's also an African doctor who probably you'll be able to relate with. We have a physician, a family physician. We also have those that have gone through the journey and they'll be able to share their experiences. We'd like you to participate. We'd like you to send it to your wives. And then, like I said, if you would like to donate, you can go to africancancer.ca or the Walnut Foundation, or you can send us email, money transfer. We'd like to bring more information in the near future. We'd like to help. We are all in the Ministry of Health to help one another. So some people, they get detected late, they get diagnosed late. But when we go around to give information, to pass information, information is very paramount. Please help us to be able to help you and help others. Thank you.
Thank you. So we've come to the end of our presentation, and I'd really like to thank Dr. Vesperini for taking the time out to providing an excellent presentation. It is really, I've seen this before, but I think I learned a hell of a lot more than the first time that I saw it. I really do appreciate it. I want to thank the panel as well for sharing their story. I want to thank the African Cancer Support Group, Bayo and Yinka, for getting in contact with the Walnut Foundation and trying to form a relationship with the Walnut Foundation. We really do appreciate it. And we really do look forward to any future events that we can hold in the future together with you guys. We're here, we do this type of thing all the time. We present to churches, we present to community groups. And, you know, we really do promote the conversation around prostate cancer in men. It's a long way to go. It's a huge journey, but I think we're making progress. And with guys like Dr. Vesprini, who are supporting us, you know, we are going to make the difference. Men are going to get tested early. That's our motto: get tested early. You know, if you have a family history, you start at age 40. Dr. Vesprini, any last words?
No, it's great. I mean, I love to see so many faces and people interested in passing that message on, right? I mean, that's what community is about: learning, passing it on, and hopefully this can help a little bit. Maybe I'll get you to watch it one more time, Ken, and then I'll hone my educational skills on you.
Yes. Okay, so we've recorded the presentations, and it will be available on both websites, hopefully by the end of tomorrow. And we're going to be sending out a survey along with the link. Please let us know how we can improve in the future. Thank you very much.
Good night, everybody.
Good night.
Good
Thank you.
night.
Take care.
Bye-bye.
Good night.
Good night.
Good night.
Thank you so much. It's great.
Okay.
Hmm. Yes,